Good morning, everyone. On behalf of our Board of Directors, it is my pleasure to welcome you to our second annual Healthcare Technology and Innovation Summit. Thank you for joining us today for this important conversation emphasizing the need for accessible healthcare, education on prevention, healthy living, and the latest technology which is rapidly transforming society's access to telehealth, telemedicine, and remote learning. These initiatives are especially important during this COVID-19 pandemic, as we understand the disproportionate impact the virus has had on the Hispanic community. HCCL's goal to bridge the existing gap between the community, healthcare, and innovation is firm and more important than ever as we plan our strategic path forward. I would like to thank our sponsors, all of them committed leaders who believe like us that a community is the foundation for a healthy workforce, a healthy community. You see, health and business go hand in hand. I think we have learned that during these unprecedented times. COVID-19 has taught us the critical role of technology to avoid or reduce disruption, and that being prepared for tomorrow began yesterday. We are proud of the impressive lineup we have put together with the agenda today and appreciate the participation of our accomplished speakers, which are ready to share knowledge and insight to help us navigate through our new reality. Let's welcome the remarks of our presenting sponsor, AT&T, and our good friend, Michael Ruffins. Thank you.
Good morning. My name is Michael Ruffin, Regional Director of Southeast Louisiana for AT&T. It's an honor and a privilege to be here with you today as the 2020 presenting sponsor of the Healthcare Technology Innovation Summit, hosted by the Hispanic Chamber of Commerce of Louisiana. Myra, you're doing a great job, and we appreciate your leadership. I appreciate the opportunity to be a part of this conversation, and I applaud all of you for the work that you're doing to cultivate the spirit of innovation, connectivity, and engagement here in New Orleans and across the state. Today we face some unprecedented challenges, but I am confident that working together, we can thrive in this environment and firmly establish our communities on a path to continued success. Over the past few months, we have navigated broadband during the age of COVID-19. It is important to take stock of what has worked, what hasn't worked, and most importantly, what actions can we take today to ensure a prosperous future for all of Americans. Let's start what was working. By all accounts, the broadband networks we all depend on, FaceTime with loved ones, to collaborate with teachers on homework, and to attend classes, and to Zoom into office meetings, perform well under immense pressures. Despite the predictions of Americans, broadband infrastructure would buckle. It didn't. U.S. Telecom reports that the traffic of internet jumped 27% at the height of the crisis, but the country's broadband challenge rose to the occasion. As many have noted, the increase swamped broadband networks in other countries. In the U.S., however, download speeds stay steady and some actually increase. At the same time, we recognize that while our networks were meeting consumer demand, obstacles to connectivity remain for some of our neighbors. To help meet those needs, we have expanded eligibility to access from AT&T, our low-cost broadband service. We have also worked extensively with our schools and state and local leadership to provide devices and services that help bridge the connectivity gaps for underserved communities in urban and rural areas. We have also expanded programs and services offered by FirstNet. FirstNet can be used daily by first responders for emergency medical services to ensure that patients receive vital information through telehealth services. Doctors and nurses can video chat with their patients, as well as send video, medical imaging, and other information to people within a medical network that need them. And because FirstNet routes all first responders' information through a dedicated network, it's built with enhanced security and reliability, ideal for when sending medical and patient information. By making it easier for doctors to remotely connect with patients, we're doing what we can to help keep Americans safer and healthier. In short, we're exploring many options to keep communities connected, and as a result of decades-long commitment, no one connects more Louisianans than AT&T, and we're proud of that. And while we are proud of the work being done by AT&T employees across the state, we also know more needs to be done. We have to continue to work to strengthen, modernize, and densify our network. To accomplish this, we will continue to deploy fiber, building on the millions of miles of fiber optic strand that we have stretching across Louisiana. We will continue to build out our 5G footprint in the state. We have had 5G available here in New Orleans since 2019, and today we have expanded that service footprint across the market. We have also brought 5G service to 13 additional markets within the state of Louisiana. We will continue to enhance our wireless network by upgrading the equipment on our wireless towers, while also deploying small cells to improve network access, capacity, and reliability. We're committed to the strength of the city and the state because we know how important connectivity is to our neighbors and to business owners like you. Modern, high-speed connectivity helps you connect with customers, helps you be successful, helps you grow your business, and most importantly, create jobs. And as we continue to work to deliver the connectivity businesses and residents need, we look forward to working with you to spur innovation and confidence in our business community. Thank you again for the opportunity to work with you, and most importantly, to be a part of this conversation.
Thank you, Michael, for those wonderful remarks. And now it's my honor to introduce our keynote speaker for the day, Dr. Leonardo Sewan, Chief Academic Officer and Senior Vice President of Ochsner Health. Dr. Sewan graduated magna cum laude from Loyola University in New Orleans with a Bachelor of Science in Biological Sciences. He earned his Doctor of Medicine degree at Louisiana State University School of Medicine in New Orleans, graduating with Alpha Omega Alpha honors, an elite designation recognizing excellence in scholarship and the highest ideals in the profession of medicine. Dr. Sewan became an associate professor with the University of Queensland School of Medicine in 2009 and was instrumental in implementing the University of Queensland School of Medicine curriculum at Ochsner Clinical School, facilitating the achievement of accreditation from the Australian Medical Council, California State Board of Medicine, and recognition from the New York State Board of Education. So welcome, Dr. Sewan.
Thank you very much. Truly a pleasure to be with you today and share with you an update as we talk about technology in medicine. You know, I think COVID really has revealed some of the challenges and also opportunities for us with technology. Now, I'm going to focus more on COVID and an update on COVID, including vaccines, treatments, and then the latest data on masks, which I think is important. But I think it's important to understand that COVID really has accelerated telemedicine in healthcare. When we looked at Ochsner that had been developing an infrastructure to do telemedicine, we had about 5,000 telemedicine visits in all of 2019. In 2020, we've already had over 170,000 televisits, to just give you an example of the acceleration and the change in medicine that COVID has brought about. I just want to remind everybody of these staggering statistics of COVID, that now globally there's been over 13 million confirmed cases, about 3.5 million in the United States, and about 80,000 plus cases. Those are those cases that have gotten to testing and tested positive. But we know through a study we did that I'll share some of the data, a prevalence study in Jefferson and Orleans, that in fact the infection rate of COVID is about 4 to 5 times higher than the confirmed cases. So if you multiply these numbers times 5, it really becomes staggering and sobering as to the pandemic and the spread across the world. And we also know not only is it significantly affecting our Latin American communities in the United States, it's having a devastating effect in our Latin American countries. So how do we get out of this? And I think Winston Churchill's quote is very appropriate here, because we kind of been on this little roller coaster ride around COVID. And he spoke to this in World War II, but you know, we got to understand, especially after we saw cases decrease in New Orleans area, that this is not the end, this is not even the beginning of the end, this is just perhaps the end of the beginning. COVID is going to be with us for a long time, and we all need to adjust our lifestyles and our public health and the way we carry ourselves and do our business to accommodate and be safe with it. And it really only ends one of two ways. And one is that around 60 to 70% of the population, so you're now talking about 200 million Americans get infected, and you get to something called herd immunity. And what herd immunity means is that you've been infected, you develop neutralizing antibodies that would prevent you from getting reinfected, and at some point when you have enough people infected, the virus can no longer spread from person to person. Or we develop a vaccine, and then it's not just developing a successful vaccine. I'll talk a little bit today about what's on the horizon with vaccines, but it's also operationalizing and vaccinating about 200 million Americans so that we can get to herd immunity via the vaccine. And that in and of itself is a big undertaking. So I want to just talk a little bit about our community. And so the Ochsner Health System in May, we did a prevalence study in Orleans and Jefferson where we randomly selected citizens of the two parishes and had them screened. And we did two things. We were actually one of the first studies in the world to not just do a serology test to see if you had ever been infected. We also, at the time that we tested you, did a PCR nasal test to see, are you infected right now? So we did both. We did, are you infected right now in the week of May 15th in Orleans and Jefferson, and have you ever been infected? And by randomly selecting a part of the community that is a mini Jefferson and Orleans, that represents Jefferson and Orleans both by geography, by age, by ethnicity, by race, we create this much like a political poll would estimate for an election, we can estimate how widespread COVID is in our community. And what we found was that about 8% of the community was infected in the week of middle of May. And so if 60% is what we need to get to herd immunity, we're a long way from herd immunity. And we're in this long, long road to have the virus be with us. If you look at Jefferson, you can see we're looking at about a 7%, and you can see Orleans has a little bit higher prevalence as of May, about 9%. But I want to draw your attention to a couple of other numbers here. One is the disproportionate share that blacks in our community have borne with this disease. And in Orleans, you can see 12% of the infected population was black compared to 4% for whites in Orleans. It's a little bit better distributed in Jefferson, but then look to the bottom to Hispanics. Although in Jefferson, Hispanics make up 14.5% of the population, it had a very high prevalence of almost 9% of the Jefferson Hispanic population having been exposed to the virus. And so the Hispanic population is also bearing a disproportionate burden with COVID-19. In one of the other big findings we had is really on the red lines here on the slide, and that is when we tested people with the PCR to see, are you currently infected? And we found people that were currently infected and had not developed antibodies. So that means they must be early in their infection, because in about 2 weeks, you develop antibodies against the virus, and we can detect that, which is how we know if someone had been infected 3 months ago. So these people were early in their infection, at least within the first 2 weeks where they have not mounted antibodies. And then those first 2 weeks, we know these people are very infectious. And so a couple of alarming things. One is that about 1% of the population in the middle of May in Orleans and Jefferson were very infectious walking around our community. Two, among that 1%, so that 1% is, about 7,500 people. Among that 7,500 people, 74% of those had no symptoms. So it was actually one of the first early studies that now has the CDC reporting, and it, in fact, cites our study as part of the reason they report, that up to about 40% of people who get COVID, we now understand, will be asymptomatic, meaning they will have no symptoms. So think about how scary that is when we don't have symptoms, but we're infectious, and we have high levels of virus in the back of our throats and the back of our mouth, and we're out in the community, out and about, not even knowing that we're infecting others. And if we look by zip codes, I think this is very important. This is the prevalence, and so there's two things. On the top slide, it's people that were actively infectious, shedding virus in the middle of May in Orleans and Jefferson. On the bottom one are those who've been exposed, that have been infected at some time. You can see on the bottom one, the red zip codes were people that had been infected, and what is very hot were New Orleans East and the West Bank, and that is exactly what we saw in March and April as to a lot of the cases coming from. But if you look at people who are infected right now in the middle of May, look at the two zip codes in Kenner, 70065, 70062, which is North and South Kenner. And we know there are significant large Hispanic populations in those two zip codes. And in fact, what we saw after this prevalence study, middle of May, is very high rising cases in those two zip codes for the next 6 weeks. In fact, those are still hot spots for our area, 70065, 70062. I want to switch a little bit and go into vaccines, and as that is one of the ways this ends. And so there are about over 100 different candidates being evaluated worldwide with regards to vaccines currently. The majority are really targeting something called the spike protein, which are those big things sticking out of the model there, that big red, spikes sticking out of the virus. The good news is we know that neutralizing antibodies in our natural immune response to the virus target those spike proteins. So we know that's a good target, good candidate to develop a vaccine against. There are many different ways to develop vaccines. Vaccines have been around for a while, all the way back to smallpox. We can weaken the virus, or we can kill the virus and inject it into people and let people develop a natural immune response to it. We can isolate that protein, that spike protein, and then we can inject that spike protein into somebody and let their immune system develop an antibody response against the protein, since we know that's important. And then the one that's been getting a lot of notoriety recently, and the one I just want to point you to, because the leading vaccines that you've been hearing about, both the German vaccine that's partnered with Pfizer, the Moderna vaccine, which is the NIH partnership, those leading vaccines are really about these new RNA and DNA vaccine technology, where you can put a piece of the RNA virus into your body, it'll go into your cells and make the protein that you would want to develop your antibody response again in the neutralizing antibodies. I think the good news around these vaccines are that technology is really modern technology, and it has allowed us to take a process that normally would take 10 to 15 years to develop a vaccine and get it to a point where we think hopefully by the end of this year, we will have some target candidate vaccines that will be effective. And just this week, Moderna shared their phase 1 data. It was published in New England Journal of 45 patients that had effective neutralizing antibodies. All 45 of the phase 1 people that were infected developed effective neutralizing antibodies. So there's hope, but we have a long way to go to be able to make sure. And as Dr. Fauci has said, it is a bit of a competition with many different companies to get to who's first. But that's a good competition because we're going to need more than one effective vaccine. And so to have multiple companies develop effective vaccines will be very helpful as we get to vaccinate the entire world. On the treatment side, I want to emphasize you that we are better than we are. We had very high mortality rates in the early epidemic centers in both New York and New Orleans. I will say we had much better mortality rates in New Orleans than New York and Seattle, where they reported up to 80 to 90% of people admitted to the ICU and being on the vent dying. That is not what we saw in New Orleans. At Oxford, we actually saw it closer to 40% of people admitted to the ICU and on the vent passing away. And I think that speaks a lot to our health systems not being overrun like the New York health systems were overrun. So remdesivir is promising. It's got to be early on in your respiratory failure. And although it hasn't shown a survival benefit, it does seem to help people get out of the hospital quicker and perhaps have a less severe case. Hydroxychloroquine, which has now become notorious because all the politicizing around it, there's not been any good studies, early studies that show it's beneficial, especially if you're sick. But there's a recent study saying it may be beneficial in the early stages. So stay tuned. I don't think the chapter is closed on hydroxychloroquine. And there's a large study called the HERO trial going on around hydroxychloroquine to see if it can help prevent people that are at high risk to get it from actually getting it. So stay tuned on that. Convalescent plasma, I think it's too early to tell. Many centers, including Oshner, are collecting convalescent plasma, and we are using it to treat our patients, but I think we're just going to have to wait and see if that pans out. Tocilizumab is an anti-inflammatory. We know that one of the reasons certain people get very, very sick with this virus is they get this over-exuberant inflammatory response towards the virus, and so trying to tackle the inflammatory response is a treatment modality that many companies are exploring. We enrolled the first patient in the country on the tocilizumab trial. We hope that that'll be published very soon. I can't speak to it being one of the centers for it. But there are other promising agents that way. Mesenchymal stromal cells for the severe lung injury. We're part of an NIH study looking at that. And then steroids. And there was a recent study published that this has been around for a long time, but steroids may have a survival benefit in those that develop pneumonia. So early on, not a benefit, and it could be harmful. But for those who develop pneumonia, there's a really at least one, and I think we've all learned that we got to give science some time to make sure that what we discover is true. But at least there's one good study that says there's a survival benefit for steroids, so we are using that. Last few minutes, I just want to focus on a couple of studies that really have kind of revealed the impact of COVID on disadvantaged communities. So this is our New England Journal of Medicine study that we published in May, where we looked at 3,400 patients who tested positive. These were the first 3,500 patients that tested positive in the Oshner system across the entire state of Louisiana. And what we found that of those 3,500 patients, 70% that tested positive early in that epidemic in March and April were black. And if you look at the population of Louisiana, it's about 30%. So there's clearly a disproportionate burden being borne by blacks. The theory there is that they're the frontline workers that one had more exposure to it, and two, could not really not go to work. The other telling thing that we found is that, the other associations were Medicaid, living in certain communities. So if you live in a certain community and there's a high infection rate in that community, you're more likely to spread it. Living in dense households. And then when you consider those things, you go, okay, that makes sense, that if it starts to spread among frontline workers and they go back to their communities and bring it to the communities, that's where there's going to be a disproportionate. The other thing we found, though, is that blacks also disproportionately get admitted to the hospital. So it's not just that they were disproportionately getting infected, they were also disproportionately getting admitted to the hospital. And then you go, well, why? Well, what we know is that people who have a rougher course, have a higher infection with this, are people that have comorbid conditions. They have diabetes, obesity is turning out to be a major risk factor for poor outcome with COVID, hypertension, chronic kidney disease, chronic lung disease. And when you look at our community and you look at the community in Louisiana, we're not a healthy community. You know, Louisiana tends to rank 49th or 50th in health almost every year. And then if you pare it back a little bit more and you go, well, where's the poorest health in Louisiana? It's among lower socioeconomic communities, it's among blacks, and it's among Hispanics. And I've said earlier today that we can probably take the word black out and put Hispanics, and we would find the similar findings. Now, we haven't done that study yet, but intuitively, I think we would find the exact same thing. The good news on it is that although they bore a disproportionate burden of the infection, a disproportionate burden of the hospitalizations, when you look at their hospital care, and there just was another article published this week in JAMA that also looked at multiple hospitals, and they had a similar experience to us, that when it was a large academic medical center with multiple ICU beds where people had experience of taking care of critically ill patients, that the mortality difference between blacks and whites was no different. And that's exactly what we found in our experience with Oxford. And then last, I want to talk a little bit about what's occurring with the epidemic today in Louisiana and in our area. And so what we've seen in March and April was a very high rate of community spread where it got out of control, and there was no way we were going to get it back under control unless we did some drastic measures like the stay-at-home measures by the governor. We also learned that it worked. You know, almost 2 weeks to where the models predicted that after the governor did a stay-at-home, we actually peaked in cases of hospitalizations and we started to decrease. But today is a very different pandemic in Orleans and Jefferson and Louisiana. We saw a much, if you look at March, the average age was 50 to 60. And if you look at today's pandemic in July, the average age is 21 to 30. So you're seeing a much younger cohort get infected. So what we see in very high case rates in Louisiana right now, we're not seeing the high hospitalization rates that we saw in March and April. And that really speaks to that younger spreading among the cohorts. Now, of course, the fear is that once that young cohort goes home and infects their relatives, things will be back where an older age group, higher risk group, and we're overwhelming our health system again. So let's pray and let's all work together that doesn't happen. And how can we work to not happen? Masks, 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 masks. So I just want to dispel some of the politicizing and the myths around masks. First, there is evidence that masks work. There wasn't in March, which is why it wasn't pushed as much. And you could say that was a mistake, and it was, but we were just trying to figure it out. But today, we have good evidence that masks work. There's a study published of a large health system in Boston that really demonstrated that once they went to a 100% masking in the hospital, they decreased the spread in the hospital significantly. And this one, I think, is a beautiful one that the CDC put out late last week, and it really is impactful. So there were 2 hairstylists in the Midwest that had symptoms and were positive. They didn't get their test results till, unfortunately, because of the delay, 5 to 7 days later. So they were still working, coloring people's hair, cutting people's hair, spending long times, long after 15 minutes, close contact. But they did one thing. They were religious about wearing their mask, and they were religious about their clients wearing their mask. And of the 139 clients that they cared for while they were highly infectious, not one of their clients contracted COVID. Masks work. And so I think we all need to mask up. We can't let our communities close again. It is economically detrimental, and we have other health issues. We can't let our health systems close. We also know if we close down our health system like we did in March and April, people who don't have COVID die, because you can't get care for your strokes and your heart attacks and your other issues. And we know that increases the mortality rate. And I think I'll leave you with the message that we do have control. This is not something that's not under our control. Collectively, all of us doing the right thing can beat COVID. I thank you very much. It's an honor to be here. It was an honor to spend time with you.
So before we continue this great day and program that we have prepared with our healthcare panelists coming up, I want to thank once again our wonderful sponsors. As you know, our event would not be possible without their assistance and support. So our presenting sponsor, AT&T, and our event sponsors, Cox, Humana, Blue Cross Blue Shield of Louisiana, Healthy Blue, Verizon, the New Orleans Business Alliance, Ochsner Health, GenCare Senior Medical Center, Hyatt Regency New Orleans, the Downtown Development District, and PSAV. Thank you very much for the support, and now we're ready for this stellar panel that we have following. Thank you.
Thank you, Myra. Buenos dias, bienvenidos. My name is Kurt Weigel, and I'm president of the Downtown Development District. It's my distinct pleasure to be here today with this august panel. I want to thank Myra Pineda and the whole team at the Hispanic Chamber of Commerce of Louisiana for the outstanding work they do, not just in putting this together, but all through the year on a number of programs and events for their membership and for the whole community. So thank you, Myra. I want to start by introducing our panel. We don't have a lot of time this morning, so we'll get right to it. I'm sure you can all find their bios on the website. But just to my left, Dr. Carlos Rodriguez is the medical director of Cardiology Center here in New Orleans. To his left, Dr. Joseph Cantor, who's the Assistant State Health Officer and Region 1 Medical Director for the Louisiana Department of Health. And just FYI, Region 1 includes us here in the New Orleans region. And then all the way at the left, properly distanced to keep us all safe, Dr. Pedro Casabon, who is the System Medical Director for Ochsner Health System. So I want to welcome you all and thank you for being here with us today. I would like to start, if we could, with a question directed at Joe, just to get us kind of in the ballpark, because you are probably the most familiar with the latest statistics. Can you just give us a quick overview? And I know we covered some of this in the keynote just prior to this, but specifically, where do we stand now on positive levels, hospitalizations, and specifically as it impacts the Hispanic community?
Thank you, Kurt. Good morning. Thanks for the Chamber so much for putting this on, and the panelists as well. It's, you know, I'll cut to the chase. It's been a bad few weeks for both the state and the region for COVID. We had this tremendous experience in the New Orleans area of having, for 13 days, what was the fastest growing outbreak in the world at that point in time, in mid to late March. We came together as a community really in a way that I was so impressed to see. I didn't even know that was possible. And we flattened the curve and we stopped the spread at that point in time in a way that very few communities were able to do. And we averted a complete disaster. I'll tell you, at the end of March, we were projecting that by the beginning of the second week of April, we would be exceeding hospital capacity by 1,000 beds in the New Orleans area. And that was a terrifying situation, and the community really came together. Unfortunately, in the 2 months since then, cases have creeped back up, and what has changed now is, whereas before it was a New Orleans specific outbreak, and the New Orleans and Jefferson parishes really, it is now a statewide outbreak. And we're 2 days out from a visit from Vice President Pence and Dr. Deborah Brooks and a number of members of their team. And the reason why they came here is because they're concerned, and they pointed out to us that in terms of geographic spread within a state, we are second only to Texas right now. So we're in the middle of a statewide outbreak right now, and the cases in New Orleans area are picking up considerably over the past couple of weeks. We have to turn this around. Now, one of the unfortunate things that has arisen in our outbreak is the degree of health disparities that have come to light. And it is most notable in marginalized communities, the African American community, and as we've realized over the past few weeks, the Hispanic community as well. There are a number of barriers here, one of which is we don't have great data because a lot of individuals are undocumented, a lot of individuals are scared to give data, and we're trying to reduce barriers at testing sites. We're trying not to ask for an ID. We're trying to make it as easy as possible for someone to get tested. The result of that is the data always isn't as robust as it would be otherwise. But I'll tell you, when we do targeted testing into Hispanic communities in Orleans and Jefferson Parish, we are seeing positivity rates between 20 and 40%. And that is terrifying. The positivity rate for Region 1 as a whole is about 10% right now. And I'll tell you, Hispanic individuals in this region are about twice as likely to get COVID right now than other ethnic groups are. So we have a lot of work to do, and my fear is that the community in this region is so marginalized, relatively new, that it's going to fall through the cracks with COVID, and families are going to suffer.
Thank you, Dr. Cantor. I apologize if I slip and call people by their first names because several of you I know have known for a while, so I apologize for that. But I would like to ask now Dr. Casabon, can you talk to us, and just one other thing, in addition to having deep resumes of various sorts, we've really got a good mix here on stage in that I know that Dr. Cantor teaches emergency medicine at UMC, Dr. Casabon is a primary care physician, and then Dr. Rodriguez is a specialist in cardiology, amongst other things. So we have the ability to look at this from lots of different perspectives. So Dr. Casabon, talk to us about how maybe this latest uptick, how it's impacting you at the primary care level.
Yeah, well, thanks for having me and having the opportunity to share some insights. For our Oxnard Health System, I manage both the primary care and the urgent care teams, and then the other group that is public-facing with patients with this condition is the emergency department. And so the challenge, especially on the second go-round, is about scale. There's a lot of patients. When you talk about a 10% positive rate, that's 400,000 people in the state of Louisiana that are now positive, and many of them seeking care. And so managing the scale of the patients that come to us has been a challenge. We talked a little bit before about technology utilization. We have utilized our tools. Dr. Sawani mentioned virtual visits has been great, a way for patients to get advice without necessarily exposing themselves to our health system and then us being exposed to their infections. We also have tools through a patient portal where patients can send emails and other things, reach out to their physicians and care teams and get information. But scale has been the challenge. The health systems are not designed to have such a huge percentage of the population seeking care, especially sort of in an acute setting.
Could you talk to us just a little more about the telemedicine aspect and the portal, how that has changed? It seems so quickly over such a short period of time, largely because of COVID, it seems.
Yeah, so interesting in this condition is that there is not actually a treatment offered, right? So, for example, in the flu epidemics that we get, there are medicines for that. In this case, it's about advice. It's about advice on how to treat your acute system, and then also socially distance and manage exposures. And so these telemedicine platforms have been great because our main offering to the public today is understanding of your concerns and then advice on how to manage. And so the telemedicine platforms have been great. Virtual visits, like Leo said, we went from a trickle to 85% of our primary care visits during the months of March and April were based in telemedicine. So you can give a lot of advice and you can get a lot of information from a patient without necessarily having to see them physically. We have this, like I said, patient portal, which allows emailing of messages that may not be super urgent. So maybe, what am I going to do about my son? The camp wants this and that precaution, et cetera. That's not something that necessarily somebody needs to come in to clinic or that needs an answer immediately. It can come this afternoon, et cetera. And so those platforms have become invaluable. We wouldn't be able to manage the needs of the community without this electronic platform.
Great, thank you. Dr. Rodriguez, we first met because our children are in school together. Could you speak to just a moment, because you and I chatted about this the other day, about the impact, and I know we're still trying to figure this out, on the opening of schools. And I'm asking you to step out of your cardiology expertise a little bit here, but since you and I had a little chat about that, I think it's fascinating. It's on a lot of people's minds right now.
Well, first of all, I want to thank Mayra and the Hispanic Chamber of Commerce for putting this together. This is awesome. I know that this is going to continue on for many years. Yes, we did. We were on the same board when our kids were in middle school. And this is scary, and it's scary mostly for parents who have kids in school. We want our children to go to school. There's no question about it. Some of us need to have the children go to school because a lot of people have to work. The concern is that they are at risk of not only getting the virus, the coronavirus, a risk of spreading it to other children, and the risk of bringing it back home. And it's been politicized, unfortunately, nationally, but we have to make sure that we are in the same frame of mind in terms of we're trying to do the best for everyone, for our children and for those people who are at risk. And I've been thinking about this when I have to talk to my school about it. I think that one of the things that we should do is there are some parents who want their kids to go to school, but there has to be some safety put into it. I've heard about the hybrid portion of the schools, and I think that's really important. I think to open the school and then have a full class, it puts the kids at risk, it puts the teachers at risk, it puts everybody that works at the school at risk, including the families already. I'll give you an example. My son is in the cross-country team, and the coach came out and said, look, we're allowed to practice. So we're going to meet and practice on the regular basis. I told my son, I said, I'm sorry, but you're going to practice on your own. Last week, 2 of the kids already tested positive. Everybody was quarantined. So it will happen. This is not a question of, is it going to happen? It will happen. So I think the schools have to probably ask the parents, do you want your kid to come to class? And those kids can probably go to class. And those that don't have to go to class, that can do it from online, can stay home. So I heard that St. Tammany parish, 65% of the parents want their kids to go to school. Good. Let the 65% go and the other 35% stay at home and do online learning. And I think we need to work together to be able to be safe.
Yeah, that's fascinating because, you know, most of what I've heard so far is basically an arbitrary split, half and half, right? But you're suggesting an opt-in.
Right. I
option
think they
instead.
can actually ask the parent and see what percentage they get that want to send the kids to school.
Okay. Dr. Cantor, as much as you're at liberty to, I know that you work for the governor, and so you know, I know there are things that you can say at certain times, right? But you're the master of public health up here. Can you handicap this for us? Tell us how you think it's going to play out based on what we know today, and we know that things are constantly changing. But what school is going to look like?
That's the million-dollar question, Kurt. There are no good choices, just tough situations, really. And the risks are real on both ends of it. There is no question that there is a harm. I'm not a childhood development specialist, but there's no question that there is a harm to disruption in formal education, keeping kids out of school, isolation for kids. I mean, they need to interact with kids. They need to have social situations. There's a real harm to that. On the other side, you know, we are, I mean, to put it lightly, we are in the middle of an unprecedented event. This pandemic, there is no comparison. None of us have lived through anything like this before. The closest thing on memory is the flu outbreak of 1918 or maybe yellow fever before that. Nothing else comes close. I'll tell you, it's challenging to say what the situation from an epidemiologic standpoint will be 3 or 4 weeks from now. Really don't know. If we continue on our current trajectory, if we don't change course, no way. It will just be a disaster. It will lead to tons of spread. I don't think that's going to happen. I think we're going to be effective at flattening the curve like we were previously. I mean, I think closure of the bars will help. I think masking as it becomes more accepted, and even though it's as politicized as it is, it's getting better. The vice president stood up on a podium 2 days ago with the governor and said that he supports masking. A number of other deep red states are coming out in favor of masking. So I see the tide changing, and I think that will be effective. Now, what happens a few weeks from now, I really don't know. I think the suggestion of, you know, encourage distance learning where families want to is a great one because it does two things that are important. Number one, it limits the volume, the occupancy within a school, which is protective. And number two, it allows families to take in consideration what their own personal risk might be. And look, I live with my wife and we have a young daughter. We don't have grandparents in town. And the risk to us is not as high as it would be for a family that lives in a multi-generational household with vulnerable people there. And I would feel different about sending my daughter to daycare if that was the situation. So I would like families to be able to have that option. And even beyond that, schools, and the Superintendent Brumley was very clear about this at the Bessie meeting on Tuesday. Regardless of whether a school opens its door on opening day or not, schools are going to need to be prepared to have both in-person education and distance learning. Because even if they are in person, there's going to be disruptions. There's going to be absenteeism. There's going to be positive cases pop up amongst students and faculty. That's going to prompt quarantine recommendations. Classes are going to have to held out for a couple weeks. And those times shouldn't be going to waste. So schools need to be prepared, I think, at this point for the entire range of options.
All right. Thank you, Doctor. We have our first question, so I'm excited by that. I'm going to get to it in just a moment. I want to stick with this for just a moment because, of course, the school question also impacts something that's important to us, the Downtown Development District, which is workforce, right? The two are interlinked. So we've got social and educational and health and workforce issues all coming together here. So, Dr. Casabon, I'd like to ask you, you all are managers in various sorts in addition to being physicians. What have you seen the impact of COVID to be on your workforce, and how have you all been able to manage that?
Yeah, so the conclusions that you draw, because within the health system, you get to study yourself. And the conclusions that we're drawing through studies of, for example, infection rates in ICU workers, is that the PPE and the masking works, right? The number of patients, the number of providers that were exposed to patients positive for COVID, the number that got infected is way tinier than one might expect in the general public. So protection does work. And so one of the things that we see in health systems is required masking both for the staff and for the patients, right? So if you approach one of our clinic sites, you are given a mask and expected to wear the mask. What's interesting, though, is many of the healthcare workers face multi-generational homes, et cetera, and so they have exposures at home that then can impact the care delivery. And also, if schools, for example, don't take their students back and the kids are at the house, somebody's got to attend to them. And so we're also facing concerns about how do you deliver some of this work virtually from home. How does a medical assistant manage messages, et cetera, from a house, et cetera. So workforce challenges are, that it's the same challenges that the entire community faces, which is how do you keep your workforce up and at 'em and providing, but and minimize their risk, but also recognize that they have challenges outside of the workplace that contribute to their special needs.
It sounds like what you're saying is that if people follow the rules, then generally the risk is quite low. Correct?
The question about what's this going to, everybody wants to know what's the next 6 months look like. I think no one knows. This is a new disease on the planet. We just have to presume that it's going to be with us. And so we have to engineer methods of managing. And masking is a simple one, hand washing, social distancing when you can, things like this, putting folks, being able to interact but 6 feet apart. The net result is what we needed to deliver, but safely. We're just taking the approach, this is indefinite, and engineer for that.
Okay, great, thank you. Well, out of respect for our viewers, I'm going to ask this question. I'll throw it out there, and whoever wants to tackle it. Is the mandate to report to the administration, I guess this means to the White House administration, instead of the CDC, appropriate? How will it impact real data?
I can start on that. It's challenging for hospitals for a couple of reasons. Hospitals invested a lot in the now former system of reporting to the CDC that's been in place for a long time. And this change literally happened overnight, without exaggerating. So in the middle of trying to respond and muster workforces and, respond to the greatest public health challenge we've had in 100 years, and we're in the throes of it now, hospitals within a 24-hour period have to figure out how to meet this new obligation, which is, it's never a good practice to change a system like that midstream. That's just not good emergency preparedness, politics aside. Now, from a state perspective, we're in a good spot, and I'll explain why. It's important for Louisiana for us to give ourselves credit when credit is due, and we have one of the most robust hospital communication platforms around of any state. It's the result of successive investments in emergency preparedness in the years since Katrina, and we really have a state-of-the-art communication system with hospitals throughout the state that we coach a lot of other states in how to get there. So we will continue to collect data from hospitals the same way that we always will. It will not affect our ability to have eyes on how many patients are in beds and what type of beds in every hospital in the state. It's an added burden on the hospitals because now they're going to have to continue to report to the feds in a cumbersome fashion. But from us, I'll tell you, I can sit at my computer at work and tell you instantly what the census is and what type of patients are in every hospital, both Tier 1 and Tier 2 hospitals without the state. And that's becoming really important now because hospitals in Lake Charles are full. They're sending some patients to Alexandria and sending some patients to us. And we've got to maximize the capacity edge to edge of this state and move patients around, so that we don't get in trouble in any one location. It's a good question, though.
Good, thank you. We're doing okay here on time, and I know that Myra and her team planned this, I believe, before COVID. So I don't want to spend all of our time on COVID if we've got some other good ground to cover. And Dr. Rodriguez and I were talking, in preparation, and he was telling me just a little bit about some of the innovations in cardiology that are really leading to improvements in patient care and in decrease of mortality rates and so forth. Can you give us a little primer on what's going on in cardiology these days?
I will, but let me just make a point on COVID before we leave. The chief of ICU at Jackson Memorial Hospital, University of Miami, that's my alma mater, was interviewed about the crisis that's going on in Miami. And he basically was saying that the ICUs are all full, and they're actually sending patients to the convention centers. And he was asked one question that was so incredible. He said, what differences have you noticed in the patients now compared to the patients 2-3 months ago? And he said, the main difference I've seen is most patients that are in ICU are young patients between the ages of about 25 to 30. And not only that, but they're sicker patients. They're requiring more oxygen. They require more pressors to maintain the blood pressure, so they're sicker. There was also a study done in University of San Francisco that looked at all the 8,000 patients that were admitted to the hospitals, and they found similar findings about the fact that younger patients had a 300% increase in hospitalization compared to 2-3 months ago. So I just wanted to give that caveat because we think that young people are immune to developing this. It's changing, and we have to realize that the virus changes. It can mutate. So there are other things that happen. So I think everybody needs to be aware of that.
Doctor, just before you go on,
Sure.
now you've put another question in my head. Would either of the other panelists want to respond to that, specifically this idea that when early on during the COVID crisis, the general idea was that it was really not mutating, certainly not quick enough to be concerned about, but what you're suggesting may be that maybe it is more than we thought. Any other insights into that from the other panelists and what that means in terms of morbidity, mortality?
I know that there's a lot of investigation along those lines. Again, this virus doesn't behave necessarily like other viruses have had in the past, and so, but I'm not sure that it's been concluded yet what's happening. I understand that DNA studies have shown that there is an element of mutation. The proposal has been that it's more contagious that way, like it's more likely to be able to transmit from one to another. I'm not sure that it changes. The reports I've seen, I'm not sure we're concluding that it changes the virulence.
You know, about a month ago, we had a change in the demographics in Louisiana of who's getting COVID. And we had a big increase in young adults, age 18 through 29. And we had some theories about why that might have been. One of the theories was it coincided with opening up into phase 2. And phase 2 brought a lot of bars and restaurants and, you know, places that young adults either work at or patronize, and maybe they were out and about more. But regardless, and there were a lot of parties or high school graduation parties and bars up by LSU and all this stuff. And we heard a lot of comments, as you alluded to, that, oh, so what? You know, they're going to do fine. And there are two things that come to mind with that. One, as was very eloquently explained, they don't always do fine. And on average, there's no question that the younger you are, the better your clinical outcomes are when you do get infected with COVID. But it's not absolute. I tell you, I personally cared for a young adult who died of COVID right in front of my team in the emergency department, and we hear stories like that all the time. So it's not, I don't want any family to take solace or assurance in that. But the larger point is that this virus has a tendency to spread. It doesn't stay contained to one age group. People that are 18 to 29 have parents, they have grandparents, they make groceries, they go out, they interact with people who then interact with people who are elderly or have medical vulnerabilities or anything else. And unfortunately, we're seeing the beginning of that right now. So as of a week and a half ago, cases in the 18 to 29-year-old bracket are decreasing, and cases in the older age groups are increasing. We should not be expected when a week and a half from now, we start seeing fatalities go up. You know, death for COVID is a lagging indicator. And for someone who does pass away of COVID, in Louisiana, they became symptomatic an average of 16 days prior to that. So we are unfortunately expecting to see some increases in deaths because of that. And, you know, folks across the age bracket should know that, you know, even if you yourself are lucky and do okay with COVID, you're going to spread it to somebody else because you can spread it without having any symptoms at all. And that person might not be as lucky, and we're all in this together on that.
Thank you. All right, now Dr. Rodriguez, let's get back to you.
So very briefly, I'm going to tell you that we have had so much innovation in cardiology that have impacted morbidity and mortality in our patients. More impressive is actually prevention. Still is an innovation of prevention. We have reduced morbidity and mortality because we have been able to modify lifestyle. We have been able to modify risk factors, in particular, hyperlipidemia, cholesterol, hypertension. We have new medicines now that we can use to bring down the bad cholesterol to levels that we have never seen before. In my practice, particularly, I bring my high-risk patients to a level of LDL cholesterol to about 50 or less. And I think this is a trend nationally as well. We will see significantly less events with that. So pharmacological and prevention has been prominent in terms of innovation. Equipment and devices has also come into play. We've had defibrillators that used to be, those are special pacemakers, defibrillators, that used to be the size of a battery, a car battery. Now it's the size of twice a coin, a quarter, that can be inserted. They're wireless now. You can put it, a pacemaker through the groin into the heart. So we have, technology has improved. We're using stem cells now in 3 and 4D printers to produce patches of muscle that can be attached to a ventricle that has weakened and improved. We have artificial intelligence that can actually go around the heart when the heart muscle is weak and squeeze for the patient, so that will improve. So, technology as the chips keeps getting smaller in the nanometer range, we're making so much improvement. And there was something else I wanted to talk about coronavirus, but that's okay. Go ahead.
We've got a few more minutes here, so it'll come to you. A question from our viewers. How can we create mechanisms that will help the Hispanic community access health care in a more equitable way? Whichever you wants to start.
Well, I can tell you that that's our wheelhouse in primary care. We spend a lot of energy these days now managing social needs, social determinants of health, and then also health disparities. Much of that is dependent on the electronic medical record. The medical record collects both health data but also demographic data, and then we can study and say, what are the rates, for example, of mammography in a Hispanic community versus Caucasian community versus African American community, and then how do we implement tactics to do the extra reach that's needed. So for example, I haven't looked at it recently, but let's say there's a disparity of 10% between one group and another. You can then put extra effort on getting to that group to get their rates up and equitable to others. So, data collection is the essential part. You can't just say, well, anybody who comes by that looks Hispanic, let's just try hard on them. No, you have to really be able to get data, put it together in a package, and then do a concerted effort. And a lot of the primary care work that's, these technologies in these specialty areas are fascinating. We also need to address the social concerns that lead to not being able to get cholesterol medicines, not stopping smoking, et cetera. And so a lot of work done in social determinants and community outreach. That's how you level the playing field.
It's resources for the Hispanic community is so important. I see patients who really have no idea where to go, how to get things. And as a specialty clinic, I don't have those resources for them. As a primary clinic, they'd probably be able to do that. But we've been able to accumulate some resource information for those patients. But to be able to have the resources for them to know where to go, because they're there, but they just don't know. You have to educate them, and she said, this is where you need to go to be able to do it. I remember a few years ago, we had a clinic in the Consulate of Mexico, Ventanilla de Salud. And I have an organization called Doctors to the Rescue. We were able to provide free service for anybody, Hispanic or non-Hispanic, that will come through those windows and give information. We need those type of resources for the community.
Those are really great points, and I can add a little bit to it. And I'll tell you, it's one of the most frustrating things that I have dealt with in the past couple of years is not being able to extend accessible health care to the Hispanic community in New Orleans, particularly because the community is relatively new, and a lot of people came here to literally help us rebuild our city. So I feel like it's been just embarrassing that we haven't been able to provide a personal service. And I speak on behalf of the official healthcare system. I work clinically in emergency department at the Safety Net Hospital at UMC, and I'll tell you, I see kind of two general characteristics of a lot of Hispanic patients that come in. One is patients who have obviously delayed seeking health care for what turns out to be serious conditions for way too long. People that present with advanced stages of cancer, advanced heart failure, clearly deferring health care until they absolutely couldn't defer it anymore. And the second thing I see quite frequently is individuals, Hispanic individuals, who don't have an emergency, just obviously don't know where else to go. And so they come to the ER because the doors are open 24/7. And that tells me that people in the community are scared to seek help. And when they even do want to seek help, they don't know where that help is. And I can 100% understand why people are scared. I mean, look, the ICE headquarters is the building next door to where we are right now. The fear is real, and for good reason. I would like to tell the community, ICE would never come into my hospital. My hospital does not care what someone's immigration documentation status is. My hospital will treat for you regardless of who you are, and I know a great number of clinics across the region that will do the same. But it's been challenging to get that message out, I think, in part because the community is relatively new and still getting a foothold in the society, and I think some of the social supports are still maturing.
So it sounds like there's some, going back to what Dr. Casabon said, and Dr. Rodriguez, is that certainly there's an effort for folks who are already in the system to address health disparities, but you're saying is that there's this other issue of folks who don't even get into the system until maybe it's too late. And so it sounds like that's maybe a question for all of us to address moving forward. We may not solve it this morning in the next 8 minutes, but it sounds like a vexing issue, a challenging issue that certainly deserves our attention. I want to ask one more, anybody, unless somebody up here has the answer. I don't, but no, I think it's the kind of thing that we've certainly identified a problem. Now, how do we go about addressing that and making it better for the people who need the care? Next question, career paths for Hispanics. It starts with a statement. Career paths for Hispanics should be increased. What can be done to encourage youth? Dr. Rodriguez, you want to start with that?
Yes, I think the opportunity for them to be able to achieve a dream, give them opportunities for better schooling. We're part of an organization, the Hispanic American Association. We produce a Super Bowl to collect, to get resources and funds so we can give scholarships to talented Hispanic students for them to be able to go to a high school of their choice. So resources for them to be able to go to schools that will allow them to get the highest potential and to be able to go to universities. Also make universities affordable for them to be able to go to. It becomes very difficult when they have to work full-time in order to be able to pay part of their universities as well.
Great, thank you. Any other ideas?
I think, outreach and going out to students and trying to engage them, we're sort of the parents in this, right? Most of the people on this telecast that are watching are probably established business folks. We're the role models. We need to reach out to folks and say, this can be done. I've always thought for a student in an audience looking at somebody like me, gray hair, doctor, I've got it all going on, they have no idea how to get from there to here, and it's sort of in a way our responsibility to explain, this is what you do. First you do this class, and then and so, and then you have to turn it into reality, I think. We need to invest. So Oxnard partners with the Sukar Ball folks and the Hispanic Heritage Foundation to create a scholarship program specifically aimed at capturing students in their high school and college path and then trying to get them into a med school path. And ultimately, you know, it's our job, I think, to create pathways for folks to move forward.
Yeah, thank you for that.
Concretely.
Are there any mentoring programs in health care, health services for high school, Hispanic in particular, high school students?
So there is a partnership with some groups that get these students that apply, for example, for the Sukar Ball program to bring them in early in shadow. We also have just generic high school and college programs that students can apply to, and then they come in, and then there's a curriculum that they follow with researchers and following clinicians and lectures, et cetera, to kind of spark that interest and turn it from the, I wonder what it would be like to be in healthcare, to, well, that's what it really looks like. And seeing the reality, I think, is what then helps students make a concrete choice. Is this really right for me or not? You know, folks that have gone through the medical training all know there are folks who went to med school because their mama wanted them to go to med school, and then they get there and they're like, this is not for me. And that's a wasted opportunity, right? And so the more they can see and do, I think the better they can be. But we have to know that it's our responsibility as as role models to encourage that.
And this is an important question because it tells the community there's a lot of resources out there, a lot of organizations out there, like the Hispanic Chamber of Commerce, Sukar Ball, that we can actually come together, unify, and see how we create a mentoring program so that we give them the opportunity to come and see what is out there professionally. Not everybody has to be a doctor or a lawyer. There are other professions that are so rewarding for them to be able to do. So a mentoring program, I think, a combination of all those organizations out there, they don't have to be Hispanic, any type of organization can do that.
I like this. We're coming up with a good to-do list for after the session. Thank you, Doctor. Once again, we really do appreciate everybody tuning in for all of today's event. And so I want to ask one more question from our audience. Back to COVID, that is the issue of the day, after all. It's been said that blood type is a factor on how affected the patient is by COVID. Is there any truth to this? Anybody?
Yeah, go ahead.
There's been a couple reports, preliminary, theoretical in some sense. To what I've seen, it's nothing to really hang your hat on yet, and certainly doesn't affect anything that we're doing on the ground. It doesn't mean that if you have type A blood, you can not wear a mask or anything like that. So I think this is it's a novel virus, and we're learning stuff every day, and I expect we'll learn more about that. I've not seen anything yet to make me change anything of what I think sound recommendations would be.
Good.
It's association only that they have with the type O and the non-type O. Interesting about COVID, before I forget, and many of you have seen it probably, Tulane University has come out with a potentially synthetic vaccine for COVID. I think is promising for the future because they're right in the beginning, but there are, I guess, promising things coming out because COVID is going to stay with us for many years.
How
Yep.
great would that be if the vaccine came from New Orleans? Huh? Literally.
Well, getting back to your previous point, Dr. Kanner, it's nice to lead in things, right? So we have just a couple more minutes, and I would like to close with this on this issue, because a lot of us we've hung our hopes on the vaccine, right? Just anybody who wants to jump in. Are those false hopes? Are they real hopes? Just give us a little insight into when, if, and when.
You know, the government came out with this warp speed program in which they went from 124 industries to 14, and now they're focused on 5 industries or companies that are producing. And this is unprecedented. I mean, the vaccines usually take 10 to 20 years to come out into market. We're going to have probably a vaccine by next year. Okay, whether or not it's going to be available to be used, we don't know yet. And the thing is that they're not 100% effective. No, we're shooting at least at 75% effectiveness. So we will have a vaccine probably by sometime next year, hopefully. Whether or not it's going to be significantly effective, we don't know yet.
Okay. Well, I think I want to be respectful to who's coming up next, so I'm going to have to cut it off there. I want to thank our panelists. If we could get, from the few people in the room, a round of applause for them. And lastly, once again, I want to thank Mayra Pineda and the entire team at the Hispanic Chamber for putting this on and everything you do all through the year. Thank you.
Thank you.
And now we're ready for our next panel, which is a new modality for this year, but we will be keeping it on for next year, hopefully in person. And it's Tu Salud es Importante, a panel completely in Spanish with the goal to reach into the Hispanic community, the grassroots Hispanic community, and all the questions out there. So today, I'll turn it over to the moderator of this panel, our good friend from Jambalaya News, Brenda Murphy. Thank you.
Buenos días. Right here. Buenos días. La verdad que estamos en un panel de lujo esta mañana. Gracias siempre a la iniciativa de la Cámara de Comercio Hispana por hacer estas cosas y no dejar que esta nueva modalidad nos impida hacer las cosas que tenemos que hacer. Nuestra comunidad hispana es muy importante y por esa comunidad hispana es que nosotros estamos esta mañana aquí. Así que tengo dos invitados de lujo, muchos lo conocen, muchos han visto sus caras, han sido ayudados por ellos. Tengo primero el caballero, ¿verdad? Porque es un hombre bendecido entre dos mujeres. El doctor Gabriel Vargas, director de cuidado primario, Jane Care. Y tengo también a la doctora Elda Margarita Tillman. Yo puedo decir muchas cosas de ellos, pero yo voy a esperar, ¿verdad?, que cada uno de ellos se introduzca con todos ustedes y que nos cuente qué es lo que están haciendo, cuál es el trabajo que están haciendo con la comunidad y cada uno, ¿verdad?, con su especialidad. Así que, doctor, por ser usted el caballero entre dos damas, buenos días y gracias por estar con nosotros.
Muy buenos días. Mi nombre de nuevo, Gabriel Vargas Bodas. He estado aquí en Louisiana desde el 1992. Vine de Puerto Rico, pero cuando estudié medicina estudié fuera de Puerto Rico también, así que tengo una amplia visión de cómo debe ser la medicina y cómo es la medicina en diferentes situaciones, desde las situaciones más privilegiadas a las menos. Mi preparación fue en medicina interna. Por lo tanto, un médico primario principalmente dirigido hacia adultos y mi preferencia siempre ha sido en los más adultos, por no decir otra cosa. El servicio que nosotros damos, en este caso en Nueva Orleans, es dirigido a pacientes de 65 años y mayores. Y la decisión de hacer esto en este particular grupo al que pertenezco es por todos los servicios que podemos dar. O sea, lo que me motivó a seguir trabajando como estoy trabajando es porque hay que pensar que la medicina hay que pensar en todos los detalles. Algo tan simple como proveer transportación. A través de los años, una de las cosas de los problemas que tenía era que un paciente tenía que verlo, pero no había forma de que llegara. Así que servimos ese servicio. Consideramos algo tan importante como la dificultad de algunos pacientes para conseguir medicamentos. Así que tenemos una farmacia para así poder proveer esos servicios, especialmente con medicamentos básicos. Todo esto incluye también servicios sociales. Los servicios sociales muy importantes porque los individuos
están con nosotros 20 minutos, 30 minutos, a veces una hora, pero el resto del tiempo está en la sociedad y hay cosas que son difíciles de conseguir, especialmente en nuestra comunidad. Hay que ser prácticos, o sea, muchos son personas que llegan aquí de hace poco y no tienen la facilidad para conseguir ciertos servicios que son esenciales para la práctica de la buena salud, aparte de una pastilla. Así que he estado aquí posiblemente ya una tercera parte de mi vida y estoy contento de estar sirviendo particularmente a la comunidad de Nueva Orleans y en especial a los hispanoamericanos como yo.
Excelente. Doctora Margarita, su turno.
Muchísimas gracias, muy buenos días. Me siento muy honrada el día de hoy estar ante ustedes y por la invitación para poder representar la comunidad latina. Estoy pues ante ustedes para decirles que mi nombre es Margarita Olivares, soy de Honduras, soy médico graduado de la Universidad Autónoma de Honduras, hice un año de especialidad de anestesiología y como muchos hispanos venimos a este país, ¿verdad? Grandioso, con tantas oportunidades, con muchos sueños. Cuando vine acá a Estados Unidos tenía una misión y era pues de venir, pasar los boards y luego aplicar a una especialidad. Pero cuando comencé a ver la realidad de nuestra comunidad latina, entró otro amor, otra pasión por la que yo también quería hacer y servir. Y eso surgió pues a través de poder comunicar, poder guiar y poder orientar a esta comunidad latina que muchas veces, como hablábamos con el doctor, se ha encontrado desamparada por muchos años. Por lo tanto, a mí se me presentó la oportunidad de trabajar con una empresa magnífica como es Access Health Louisiana, el cual es una red de centros de salud, el cual están localizados en toda Luisiana, que tiene una misión increíble para poder brindar servicio de salud a este tipo de comunidad que no tenía acceso en algún momento o que no tenían la información para poder ser atendidos. Entonces, cuando yo entro a esta empresa, me doy cuenta que existen recursos, que existen maneras para poder decirle a la comunidad latina e incluso a los que vienen llegando y que no tienen documentos, atiende tu problema de salud. Porque hoy en día estamos ante una pandemia, el cual lo comentábamos con el doctor, que si tú no tratas estas enfermedades concomitantes o comorbilidades, este virus es aún más agresivo contigo. Entonces, debido a esto, yo he creado muchas alianzas con muchas instituciones y he creado pues una alianza fraterna con Jambalaya News, con la Cámara de Comercio y me ha dado el poder de poder seguir con mi misión, de poder seguir informando, seguir ayudando y seguir brindando servicios de salud. Access Health Louisiana también atiende a aquellas personas que no tienen documentación, que no tienen un seguro médico y nosotros estamos para ellos, para ofrecerles incluso programas que se les brinda medicamentos a un bajo costo a través de un programa 340B, el cual si el paciente, como dijo el doctor, no tiene transporte, no puede ir por su medicamento, se le entrega hasta la puerta de sus casas. Y hoy en día, pues con la telemedicina, que es una implementación maravillosa del uso de la tecnología, pues permite también que miremos incluso a aquellos pacientes que no necesitan un examen físico o un examen de laboratorio para que puedan requerir sus medicamentos o que puedan hablar con el proveedor de salud acerca ya sea de un problema de salud emocional y mental o un problema de salud y seguir atendiéndose con sus problemas concomitantes o con cualquier duda, incluso hasta la atención de los niños, que es muy importante para que mantengan sus vacunas al tiempo y evitar de que esta pandemia pues dañe la salud, pues incluso más de lo que ya estamos sufriendo, ¿no? Pues con ese mensaje yo me introduzco y me siento muy agradecida, muy bendecida que soy ante este panel. Muchísimas
Fantástico,
gracias.
fantástico. personas carismáticas, con don de gente, con deseos de ayudar. Eso es lo que nuestra comunidad necesita. Así que ya conocimos rápidamente al doctor Gabriel, ya conocimos rápidamente a la doctora Margarita. Ahora vamos a entrar en materia, porque hay muchas dudas, hay muchas preguntas. La gente necesita saber qué hacer, pero también la gente necesita saber sus experiencias. Así que vamos a ir avanzando rápidamente, ¿correcto? Empezamos con el doctor Gabriel. Doctor, ¿cuál es el peor caso que usted ha visto entre personas que no creían en el COVID-19?
Pues sí, practicando with GenCare, he tenido varios pacientes que han estado practicando seguridad en la salud, la prevención, usando las máscaras, lavándose las manos, manteniendo la distancia, manteniéndose en la casa el mayor tiempo posible. Y me han contado, siempre refiero a un caso en particular de esta pareja que tenía un vecino de 29 años que se burlaba de ellos, decía, eso no existe, eso no es nada, a mí no me va a pasar nada. Desgraciadamente, ese vecino se enfermó y en 5 días falleció.
Wow.
29 años sin ninguna aparente condición de salud. Claro, yo le cuento esto a otros pacientes para que lo cuenten a otros familiares, porque eso es dramático. Y lo estamos viendo, ya se habló de esto anteriormente aquí en este mismo programa, por lo tanto, para mí eso es dramático.
Doctora Margarita.
Muchas gracias, Brenda. Pues voy a compartir con tu pregunta, Brenda, voy a compartir un testimonio personal y en realidad es en mi casa. Mi esposo no creía en el COVID-19 y no lo digo para juzgarlo, lo digo para compartirlo. Actualmente tengo a mi hijo el día de hoy en el hospital de niños por enfermedad de Kawasaki secundaria a la infección por virus. Y no voy a decir por qué me pasó a mí, solo puedo decir que si a mí me pasó es para que yo diera este testimonio y para que hiciera entender a la gente que el COVID-19 existe, que nosotros tenemos que seguir las medidas básicas sanitarias para poder evitar que este virus se siga transmitiendo, como el lavado de manos, el uso de mascarilla. Afecta tanto a adultos como a niños. Y el día de hoy, pues mi hijo está en la unidad de cuidados intensivos de cardiología. Está siendo atendido de mil maravillas. Vengo del hospital y estoy aquí presente porque no quise fallar ante la presencia de ustedes para hacerles saber que no voy a hablar de un paciente, voy a hablar de mi hijo. Y estos virus existen, tenemos que ser muy cuidadosos, tenemos que seguir todas las normas de seguridad, de salud que nosotros podemos hacerlo, porque aún uno siendo médico, uno no está exento. Y nosotros tenemos que estar ahí en la primera línea de defensa para estar para ustedes, para poder protegerlos a ustedes. Y no obstante, eso también estamos poniendo en riesgo nuestra propia salud y la salud de nuestros hijos. Así que yo solo espero que ustedes entiendan que este virus existe y que tenemos que seguir adelante, tenemos que apoyarnos unos a otros para que todos podamos vencer este virus, porque no se va a ir, como lo dijo anteriormente el doctor, se va a quedar por mucho tiempo hasta que tengamos la vacuna para que nosotros podamos lograr combatirlo. Pero por lo menos yo les puedo decir que es una experiencia personal. Me estoy sufriendo, estoy aquí ante ustedes, pero este testimonio es para ustedes, para aquellas familias que no creían. Yo les puedo decir que sí existe.
Qué impactante de verdad es darnos cuenta, y nosotros hablábamos ayer, cómo es el COVID-19, porque realmente no respeta raza, religión, estatus migratorio, puede tocar a cualquiera. Y yo he perdido amigos también y he estado sufriendo esa pérdida y esa incertidumbre de no saber qué va a suceder. Nuestras oraciones, Margarita, para ti, para tu familia, confiando en Dios de que todo va a salir bien. Continuamos con el panel en español. Tu salud es importante. ¿Qué le dirían, Margarita, comenzamos contigo, qué le dirías a aquellas personas que tienen que salir a trabajar porque tienen que llevar el sustento a sus casas para que practiquen, para que tengan mejores prácticas de cuidarse, porque también sabemos que muchas personas se han contagiado en sus centros de trabajo?
Así es. Pues bueno, a esas personas, así como nosotros los médicos, ¿verdad? Que tenemos que estar fuera trabajando, luchando por ustedes, yo les puedo decir, todas nuestras familias de una u otra manera están dependiendo de nosotros, ya sea siendo proveedores de la casa. Y pues lo que yo les puedo decir es que en mi práctica personal, si ustedes no se tocan sus ojos, su nariz y su boca, recordemos que no va a haber esa entrada de este virus. El virus entra por mucosa. Entonces, si nosotros evitamos ese contacto con nuestra cara para que pueda entrar por mucosa, vamos a hacer la gran diferencia. Si nos lavamos las manos constantemente, va a ser una gran diferencia también. No necesariamente utilizar el gel antibacterial, porque es un bacterioestático, no es un bactericida. Pero el jabón, el agua y el jabón, tenemos entendido de que la capa superficial de este virus está llena de fosfolípidos, o sea, de grasa, y se destruye simplemente con agua y jabón. Y eso creo de que todos tenemos al alcance de nosotros. El uso de la máscara, como yo hice un video para el Consulado de Honduras y les dije, ¿por qué es tan importante? Porque muchas veces estamos en una línea y naturalmente el ser humano como una respuesta tiene que toser o al hablar o pronunciar ciertas palabras como la F, libera pequeñas gotitas respiratorias que probablemente seamos asintomáticos positivos y no lo sepamos y podemos contagiar a otra persona. Guardar la distancia, ¿por qué? Porque estamos protegiendo nosotros mismos y estamos protegiendo a la persona que está enfrente también. Entonces, el uso de la mascarilla, el simple hecho de lavarse las manos con agua y jabón, si no tenemos el acceso a agua y jabón, pues el gel antibacterial que nos va a ayudar pues a protegernos por ciertos minutos y mantener la distancia para poder proteger al prójimo y nosotros mismos.
Doctor Gabriel.
Bien, tengo que decir que la doctora ha realmente resumido magníficamente bien la necesidad. Hay poco que añadir. Usen agua y jabón y si no están en casa, los sanitarios, pero no usen eso en la casa. Insisto en las mascarillas, algo tan simple como cuando trabajaba en hospitales de tuberculosis hace muchos años atrás, lo que teníamos eran mascarillas y en esos años, estoy hablando de los 70, lo que teníamos eran mascarillas de tela y aún así nunca me infecté. Y ese sí es un virus, es una bacteria que sí se sabe que se puede transmitir por el aire. Tenemos la ventaja ahora de que aparentemente es por saliva, así que con más razón las mascarillas ayudan. Es imposible en un trabajo mantener constantemente 6 pies o 2 metros de distancia. Por lo tanto, vamos a rozarnos. Aparte de que tenemos que hablar y a veces algunas personas no pueden hablar fuerte, tienen que acercarse. Por lo tanto, la mascarilla hay que acostumbrarse a tenerlas todo el tiempo. Aquí, por ejemplo, no las tenemos porque estamos sentados, pero el momento en que nos paramos, sacamos la mascarilla, la tengo aquí atrás, porque es esencial, cualquier tipo funciona. Vamos a ponerlo de esa forma, algo es mejor que nada.
Gracias, doctor, precisamente por decir eso. O sea, si no puedes tener una N95, si no puedes tener una tan sofisticada, pero funciona. Cualquier tipo de mascarilla, pero funciona.
Exactamente. Así que es importante, o sea, no realmente sería redundar lo que dijo la doctora porque lo dijo mejor que nadie. Pero insisto, mascarillas de cualquier tipo, constantemente y recuerden, esto va a pasar. que tal vez tome 6 meses, un año, bueno, pero lo importante es que estemos aquí en 6 meses o en un año para entonces poder estar de nuevo como ahora. Yo pasé por la crisis del HIV, del AIDS, cuando en hospitales, manejando pacientes en el hospital, y aquí estoy, en tiempos en que no había cura. Por lo tanto, se puede hacer.
Fantástico. El tiempo avanza. Recuerde que usted puede ver la retransmisión de este programa que estamos haciendo en vivo de Healthcare Technology and Innovation Summit, que se está pasando virtualmente. Pero si no lo puede ver ahora, lo puede ver más tarde. Pero nos quedamos siempre con esta buena información. El tiempo avanza. Una última pregunta, ¿verdad? Para los dos. ¿Cómo hablar con los niños del COVID-19 en casa, especialmente con la preocupación que hay ahora de que se reabran las escuelas y que los niños tengan que estar presentes en los salones de clase? Doctor Gabriel.
Bueno, ahí me cogí un poquito porque...
Bueno, con los nietos, doctor.
Ya, lo
con
que
los
pasa es que todavía no
nietos.
tengo, pero he pensado en eso porque mi esposa enseña y va a tener que enfrentarse a eso. A los niños, a un nieto, yo le diría, hay que tener cuidado, hay un pequeño insectito que no se puede ver, que puede enfermarte, puede enfermar a tu mamá y a tu papá, y puede enfermar a tus abuelitos, y hay que tratar de lo más posible seguir las instrucciones de tu maestra. Así que si tu maestra te dice que tienes que quedarte con una máscara, ponte la máscara. Si te dice que te laves las manos, lávate las manos. Y cuando lleguemos a casa, volvemos y hacemos lo mismo. Porque hay que cuidar a tu papá, a tu mamá y a tus abuelitos.
Excelente, excelente. Margarita.
Ay, Brenda.
Y recuerden que nos están viendo muchos padres, ¿verdad? Y hay una preocupación real. Vuelvo al caso de tu hijo, estaba en casa siendo cuidado, luego exponerlos da un poco de pánico, pero ustedes son los especialistas de la salud.
Pues bueno, yo considero que también nos deben dar la oportunidad a nosotros como padres de decidir si vamos a permitir los niños recibir clases virtuales o estar en clases presenciales. Yo creo que es una muy buena opción. Lo digo porque en mi caso, doctor, pues estoy pasando una situación muy fuerte y yo creo de que después de esto no me voy a sentir lista. Y yo creo que muchos se van a identificar conmigo, pues, porque muchos están pasando por una situación igual. No se van a sentir listos para mandar el niño a la escuela inmediatamente o mandarlo a un daycare, porque ya que se enfermaron, todavía están en el proceso de recuperación y necesitan que sus defensas pues estén en las óptimas condiciones para poder estar pues en una clase presencial. Entonces, que se le dé la oportunidad por lo menos primero al padre de decidir y segundo, así como en algún momento de nuestra vida nosotros hicimos mucho énfasis de promover la educación sexual en los niños, así tenemos que promover la educación sanitaria, las medidas básicas de cómo lavarse las manos, de cómo utilizar una mascarilla. Va a ser muy difícil en niños que lo entiendan porque es una nueva modalidad, lastimosamente, pero si nosotros en casa y los maestros, como dijo el doctor, y los medios están atacando de manera positiva, usa tu mascarilla, lávate las manos, de una manera va a entrar en el consciente de los niños y lo van a lograr aplicar. No obstante, va a ser muy difícil porque hemos siempre promovido los deportes y en este caso, pues, hay un contacto, sea o no. Entonces, vamos a tener que aprender a decidir la salud también física del niño, ¿no? O mantenerlo restringido. Pues, por el momento, como dijo el doctor, vamos a esperar, necesitamos una espera, por lo menos ya sea que la vacuna aparezca o unos meses de que eventualmente obtengamos una inmunidad colectiva, porque yo digo que eventualmente todos en algún momento vamos a haber estado expuestos al virus y no significa que todos vamos a desarrollar la enfermedad. Pero con tal todos tengamos opciones y que promovamos medios de comunicación, escuelas, maestros, nosotros que estamos aquí, a los niños, así como se les habla en chiquito por el amor que uno les tiene, así hay que hablarles como en adulto, que es una pandemia y que tenemos que también cuidarlos.
Wow, creo que hemos tenido un panel de lujo esta mañana. Gracias a la Cámara de Comercio por hacer posible que esto pasara. 30 segundos, ¿verdad? Un mensaje final para los que están conectados con nosotros en este panel. Tu salud es importante. Doctor.
Bueno, lo importante, de nuevo, es saber que esto es algo temporero, es un sacrificio que hay que hacer, de la misma forma que muchas veces decimos a nuestros veteranos, gracias por su servicio, ahora nos toca a nosotros como comunidad sacrificarnos por ellos. La mayoría son personas de alto riesgo, han sufrido situaciones horribles por la defensa de nuestro país y ahora nos toca a nosotros, especialmente los que se consideran patriotas y a los nuevos patriotas que están llegando, que hay que sacrificarse. Si esto es un sacrificio, lávense las manos, mantengan la distancia, pónganse las mascarillas y respeten a nuestros compañeros.
Doctora Margarita.
Muchísimas gracias a todos y pues les quiero decir que a todas aquellas personas que vienen llegando al país, que ya están aquí, atiéndanse. Tengan o no tengan documentos, vayan a los centros, tomen sus medicamentos, no dejen de desatenderse porque recordemos que esta enfermedad va a atacar a los más vulnerables, mantengan a sus niños con sus vacunas a tiempo, utilicen las medidas básicas sanitarias y así vamos a tener una buena manera de prevención.
Muchísimas gracias por haber estado con nosotros, gracias por haber estado pendiente de este panel. Siga porque la programación virtual no se termina, continúa. Gracias por haber estado con nosotros y haber compartido sus experiencias y esos consejos tan valiosos para nuestra comunidad. Gracias. Feliz mañana.
Gracias.
Gracias.
our special presentation speaker, Dr. Somesh Nigam, Senior Vice President and Chief Analytics and Data Officer for Blue Cross and Blue Shield of Louisiana. Dr. Nigam is the Senior Vice President and Chief Analytics and Data Officer at Blue Cross and Blue Shield of Louisiana, a nonprofit health insurer and the oldest and largest in the state. He has demonstrated how big data, in conjunction with artificial intelligence, can enhance collaboration between insurers and doctors, hospitals, advance a value-based payment system with more accountability, increased transparency, and improved patient engagement. He has championed cutting-edge data initiatives, working with other business areas to use reporting and analytics to cut waste and fraud, reduce cost, and manage quality. Nigam is a sought-after speaker at national healthcare analytics and conferences and forums. He has published numerous articles in peer-reviewed journals. He earned his Master of Science and doctorate degrees in chemical engineering from the University of Michigan, Ann Arbor. And I'm sure you've seen him lately because he has been one of the featured speakers for many of the governor's press conferences. So without any further ado, I present to you Dr. Nigam.
Good morning. Thank you for inviting me for this presentation. I'm really grateful to Hispanic Chamber of Commerce. It's a very unique times that we are talking today, meeting and having this dialogue in our history. None of us could imagine literally a few months ago, that the entire world would be dealing with this pandemic. And pandemic has done many things. It has actually exposed the chinks in our healthcare system. And it's actually brought the focus particularly to social determinants of health and how certain communities are much more vulnerable to not just COVID, but really all kinds of chronic diseases. And we need to do a better job as a society to address these issues. So I'm hoping that today's presentation will allow us to think about, bring some of those issues in focus, and also really talk about the role of technology, how technology, and particularly the cutting-edge technologies like artificial intelligence, data, and advanced analytics can help us get closer to our goal, can serve as really tools for improving healthcare overall for all Louisianans. I'll use a few of the PowerPoint slides today to make my point, and hopefully we'll have enough time left at the end for a dialogue. So let me share my presentation with you. We in Blue Cross Blue Shield of Louisiana have invested heavily in data and analytics, and especially the advanced analytics component, which you probably have heard about. Terms such as big data, artificial intelligence are talked about quite commonly. And of course, there are many things that these technologies can be used for. We are particularly interested in how this technology can be used for improving healthcare. My name is Somesh Nigam. I'm the Chief Analytics and Data Officer for Blue Cross Blue Shield of Louisiana. My contact information is here if you wish to reach me. So let's talk about Louisiana. Louisiana has a number of healthcare challenges, as you all know. More so than national picture, more than half of the state has at least one chronic conditions. And these chronic conditions contribute to almost 2/3 of all healthcare costs. These are diseases such as diabetes, hypertension, kidney disease, other chronic diseases related to that. And you perhaps realize that with COVID, some of these conditions have also taken a center stage. Folks with chronic conditions are a lot more vulnerable to the effects of COVID. Of course, many of these chronic conditions are prevented, or they can be prevented or controlled through better diet, exercise, preventive measures, screenings. And if we are able to do that, that will obviously lead to improved health, but also lower cost. There's been a lot of interest in what are called social determinants. So social determinants are all the things that happen really outside the healthcare system. These are things like where do people live, what type of built environment they have, what kind of parks or walkways they have access to, do they have access to healthy food, are they getting appropriate education, are kids getting the right type of environment to grow and thrive in. So all of that combined is referred to as social determinants of health. And as it turns out that social determinants of health by some measure account for vast majority of our health. So while access to healthcare is the key issue, and having great doctors, and when you are sick, being able to get to great institutions and have them support us is important, social determinants are really what determines how we get there. So unfortunately, Louisiana has a lot of challenges there as well. We rank really low in social determinants and all the way to the bottom, 50th. Sometimes the joke is, depending on what year you look at this data, it's either us or Mississippi or Alabama. Sometimes we say, thank God for Mississippi. Sometimes Mississippians say, thank God for Louisiana. So it is something we really need to work our way out of. However, our clinical measures actually are reasonably good. We are average or above average in many of the clinical measures. And a lot of social determinants, obviously, as you realize, are interlinked with poverty. And we as a state have a lot of challenges. And poor rankings on poverty and obesity, et cetera, really do put us at the end. COVID-19 crisis pandemic has amplified what's going on as a result of these adverse social determinants. What are the outcomes amongst racial and ethnic minority groups? As you have heard, many of the minority groups are very adversely impacted and are particularly vulnerable to the complications of COVID. Here's data from CDC, and you can see that this is national data, that Hispanic, particularly Hispanics, Blacks, and Native Americans are much more impacted, 4 times or greater than non-Hispanic population, whites and Asians. So clearly that gap is right there, and we see that in Louisiana, and we certainly see that in national statistics. So what can we do about it? How can we improve our healthcare? One way to think about is better data leads to better outcomes. Can we get all the data on healthcare, all of our health, how we lead our lives, how do we access healthcare for really from early stages of disease to chronic conditions and late stages, and what kind of outcomes are being delivered, and can we then utilize all that data, whether it is our claims data or laboratory data or pharmacy data, interactions with clinical management and customer service, and can we combine it all and utilize state-of-the-art tools such as artificial intelligence driven tools, and then convert them to actionable insights. And that's really where we have invested. Some of the largest investment Blue Cross has made have been in that area. And let me talk about them a little bit. Just to talk about technology, technology has come a long way. Now, all of us carry our mobile devices, and we actually utilize technologies a lot of times without even knowing about it. Google is able to predict what are you going to search for. For example, Amazon is able to predict what are you likely to buy. And certainly we are all used to GPS technologies or calling Uber cabs and so forth that allow us to go from one point to another, regardless of whether there are roadblocks on one way, it'll redirect you. All of those technologies have taken us from descriptive view of the world, which was very much what we did, the way we did business until a few years ago. How did things happen? What happened in the past? Now we are talking about what is going to happen. And we're increasingly talking about it, what should we do about it to deliver a better outcome? A lot of technology has been put into this. You certainly need to integrate a lot of data. I talked about that already. But in addition to data, you also need to work on something called population health. You need to use this data and then try to use it across populations to identify who is particularly using predictive models at risk for hospitalization, readmission, emergency department visits, and perhaps even things like customer complaints that could arise because folks are not getting appropriate access to healthcare, for example. Once you know who's vulnerable, you can apply all kinds of interventions. These interventions tend to be expensive, but you can apply them if you can identify specifically what works for who. And once you are able to apply those interventions, you can actually evaluate outcomes and see whether it actually did work or not. So this is the overall paradigm for data-driven innovation. We've invested in many technologies. One of the platforms that we have developed at Blue Cross is called PI, Platform Pi, short for Performance Insights, with all of this technology built in. And it's being utilized to empower groups, many of the groups who buy insurance from us, employer groups, providers who we have value-based contracts with, and also for our members directly. So the idea is that can we use this technology and then describe what is needed at any given time in a timely fashion to improve the healthcare going from an adverse effect to an improved outcome. One of the new data feeds that we are very thrilled about is so-called ADT. So today, when someone gets admitted, discharged, or transferred, we get an automatic feed now. Blue Cross collects a lot of ADT data. So earlier, if you recall, when people went to healthcare system, they utilized healthcare, we got a claim sometime many days, if not weeks later. Today, when somebody is admitted, we instantly find out that one of our members has been admitted. And so we can take some appropriate action right at that point to support the member in their healthcare journey at that point. I talked about predictive models. These are the kind of models that help you predict, just like Amazon used to predict books, but today they pretty much know what we're going to buy. Those are the same type of technologies. We predict risk of hospitalization, risk of emergency department visits, risk of readmission, complaints, and many of these, we compare them to national benchmarks to try to say what is commercially available. Fortunately, we have a very strong AI team, and they have been able to build these models that actually stack up really nicely and are much, much better, really industry-leading models that we are able to use in Louisiana. A lot of our work has been published, and I can provide you with references at the end of the talk if you would like. And you would notice, like, for example, here we are talking about risk of hospitalization model. And notice that a lot of things that predict future hospitalization is, for example, past hospitalization, maybe a radiology service or some type of procedure that may have happened recently. But notice number of families and number of members in family unit is also included. If you live alone, you have 3 to 4 times higher likelihood of hospitalization because you don't have that support that you need. Some of our rural, less served communities are particularly vulnerable. So are the low income blocks. And you can imagine all of that is talking about our social determinant story. In order to manage some of this, we have launched many innovative programs. A $0 copay program is something that we launched a few years ago and have been expanding it. It covers many, many drugs for all kinds of diseases, diabetes, heart disease, hypertension, mental health. Essentially, it allows folks to get their medicines for $0 copay. And we continue to expand the program. We used to have only 5,000 members there. It went up to 50,000. And now we are targeting almost 100,000 members to be in that program. It's in our interest to make sure that people don't find a financial barrier and not then take their medicine. In Louisiana, some people from our research indicates that will walk away from a pharmacy with a prescription in their hand because of, on average, $8 copay. These folks are really trying to make a decision. Should they be spending money on medicine or perhaps putting food on the table? So clearly, this sort of program helps. We have a lot of data that shown here, different classes of medicines, whether antihypertensives or for lipidemia or for anti-diabetic diseases, such hypertension drugs such as beta blockers and calcium channel blockers. Notice in each one, all you have to look at are the colors. The green bars indicate that the actual amount of drugs that people were taking, so-called PDC measure, portion of days covered, how many more days people are taking the drug for, is going up in the green as we in the ZDC group, the $0 copay group, compared to a control group that was not offered that program. And so we're very proud of this program. It actually has improved the health of our membership. But also we found that the cost actually went down. When people take their medications, they obviously the medication cost goes up, as you can see here, by the RX cost shown in red, but folks are not going to hospitals or ER, and all of that improvement actually leads to cost savings. So net, this program actually saves money. And now we have, as I said, this is an older slide. We have we are now targeting 100,000 members to be in this program. We also have invested heavily in enhanced disease management. Earlier, we used to focus on sort of one-size-fits-all disease management. Now we have very targeted disease management programs for chronic kidney disease, heart disease, diabetes, and COPD and asthma. We also engage with folks wherever they are, not just by telephone, but also in the community. We go to people's homes or meet them at doctor's offices. And so much more engagement. A lot of it leads to education and better management of disease. What we have found is that this enhanced disease management program, again, powered with our artificial intelligence targeting, leads to fewer emergency department visits, higher prescription rates, improved clinical outcomes. So if you are diabetic, you notice much lower HbA1c values and reduced blood pressure, and all that leading to lower inpatient admission. So all of that works really very effectively as we apply technology. We recently did a large study with one of our largest group, and this group had almost 20%, 19% of the members when enrolled in care management programs. We found that every year over year, their outcomes were not moving in the right direction. And we actually had performance guarantees for chronic artery disease, CHF, congestive heart failure, and diabetes. And we wanted to take care of that. So we said, well, let's use artificial intelligence to identify exactly who is the member who will benefit and is ready for change. As we applied that, we found in this campaign that we were able to utilize very small amount of population that was actually then referred to case management, much high-touch case management, care management, I'm sorry. And we noticed that their engagement rate went up dramatically from low single digits to almost 60%. And then we also found the admission rate and ED visits went down. So all of this is leading to really good outcomes, and we are very proud of that. That technology can actually make a big difference. PI platform continues to grow. We are using it right now in conjunction with Louisiana Department of Health to track COVID. It has lots of modeling in it. I'll just take you through some of the slides. For example, right in the middle, it shows how the COVID has been going up through ADTs. It shows age distribution. There are all kinds of modeling built into it so that we can see how you can see how the disease went up, it went down, and now because of reopening scenarios, you have seen a resurgence, and our models are tracking all of that. And it allows you to then track essentially clusters that are being created so you can really reach out to those folks, provide them interventions such as contact tracing and greater support to help reduce the spread of the disease. So key takeaways now towards the end, we would like to discover and validate and scale interventions to improve health for those who otherwise would not seek care but are at risk for deteriorating health. With effective coordination, Blue Cross team working with providers can make a big difference to improve clinical outcomes and also reduce cost of care. And all of this with technology, AI, and machine learning leads to robust outcomes evaluation. So we always are finding out what works and what doesn't work, try to enhance things that work, and then cut down on interventions that don't work. And we continually are comparing ourselves to industry benchmarks. Last slide, we publish a lot of our research in national journals so that remain ahead of the curve and learn from our colleagues across the country, and also teach a thing or two that we are finding out what works in Louisiana. So thank you very much. Once again, my contact information is here. Please feel free to reach out to me, and I truly appreciate the opportunity brought about today by Hispanic Chamber of Commerce to be able to talk about some of the work that we are doing in healthcare arena. Thank you.
And thank you very much, Dr. Nigam. That was amazing insight, and we have a lot of work to do, but I think one lesson we've learned today is that we have to do this together. We have to come together as a community and work. We have a long to-do list. But with this, we arrived to this amazing panel coming up, our Technology and Innovation panel. And we have, of course, it's technology, so we have two of our speakers joining us remotely, and two of them right here with us in our studio. So with that, I'd like to welcome our moderator for this panel, Ms. Victoria Phibbs with the New Orleans Business Alliance. Thank you, Victoria, and it's your show now.
Thank you so much, Myra. Thank you for having me. As Myra mentioned, I'm Victoria Adams-Phipps, Chief Strategy Officer at the New Orleans Business Alliance. I'm delighted to be joined this morning by three leaders in technology. We have Fernando Hernandez, Director of Supplier Diversity and Sustainability at Microsoft, Jade Stokes, Scrum Master at DXC Technology, Angela Zaring, Key Account Manager at Tripolo. Thank you all so much for joining me this morning. So as Myra touched on, thank you. In this panel, we'll be discussing technology and innovation. In the midst of the pandemic resulting from COVID-19, we have seen some remarkable changes and also remarkable adoption of telehealth and telework technologies. Angela, let's start with you. I understand that Tripolo is a healthcare organization owned by Cox Communications. Can you tell us a little bit more?
Certainly, Victoria, and thank you. And thank you to the Hispanic chapter for having us. Yes, so Tripolo is part of the Cox Communications family. We're a connected healthcare solutions provider, and we're focused on enabling healthcare organizations to extend outside of their hospital walls and really treat patients from the comfort of their own home. Our platform gives clinical teams access to daily medical information like vital signs and surveys. We use wireless technology and home medical equipment, devices that are Bluetooth and Wi-Fi connected, blood pressure monitors, things like pulse oximeters, scales. And this really gives the ability for patients to be able to send their health information or have virtual visits right there in the home. And this is what we've heard about all morning from the different panelists and the different sessions. So traditionally, our solutions have been geared towards patients with chronic illnesses. Repeating again from today, we've heard about diabetes, congestive heart failure, all of these types of chronic illnesses. And these help seniors stay in their homes longer. Remote patient monitoring is also working an important piece to address the disparities of care across both urban and rural communities. The COVID-19 pandemic has really shed a light on all of these capabilities, and it's become an important part of healthcare today. And we're seeing virtual care use expand way beyond our traditional populations now that pandemics happen. The pre-existing conditions that you're hearing really complicate COVID-19 are the illnesses that really we've been supporting for years and will continue to support here.
Thank you so much for that, Angela. So within what you said, I feel like I heard a bit about the promise of connected health. And certainly we've seen rapid adoption of connected health solutions in the midst of this pandemic. Really, we've seen growing importance, growing recognition of the importance of tech more broadly. Many are looking at this moment as a moment of digital transformation. Fernando, can you share a little bit more about what digital transformation is and how you're assessing the present moment at Microsoft?
Sure. Good morning, Victoria, and thank you for your support. I just want to thank the Hispanic chapter for all the good work that they're doing here. And I think this is a very important time to focus on digital transformation. What we've seen is in the last 2 months, you've seen about 2 years worth of digital transformation compressed into a 2-month period. The proof points are what we're doing right now. Much more in the way of digital communication, whether it's on Teams, Skype, Zoom, and other platforms. To speak specifically to healthcare, what we're estimating now is that the digital healthcare area is going to grow to be about a third of $1 trillion worth of spend. So that's significant from the point of view of an economic impact. Things that you would have otherwise thought that healthcare would adopt slowly, they're adopting quickly. We're working at Microsoft, we worked with the CDC to create things like digital bots. So you can have a chat session with a bot from the CDC, and it asks you a variety of questions like a physician would. And at the end of the day, it predicts whether or not you have COVID-19. These are things that, again, typically would not see happening as quickly as it's happened. So we are fully in the midst of true digital transformation. Another example would be the colleague that just spoke before me, Angela, was talking about all these digital devices that you would use with patients. What you're going to see is those types of devices and other smart devices on your person working in conjunction with the Internet of Everything, sweeping all that rich data up into the cloud, as the prior speaker was talking about, and managing your care in a very intelligent, holistic way and much more targeted to the individual, using things like quantum computing to know what's going on in your genome. So it's the time of radical transformation in the healthcare space, great business opportunities, I believe.
Thank you for that, Fernando. So for both Angela and yourself, we have seen your agencies or companies being able to leverage some existing technologies that you already had in place, but we also are seeing within the marketplace this rapid adoption, but also this agile methodology that's being leveraged at a number of companies to respond to what we're seeing now as a result of this pandemic. Jade, I'd like to turn things over to you. At DXC, how have you all been able to leverage agile methodology within your operations, and what is really the value of businesses performing with more agility at this time?
So in terms of value in agile, at DXC in the New Orleans office specifically, we are Agile Center. So we were already very agile in the way that we worked. And so even our office space, I don't know if you've been there or not, is really open to encourage collaboration and rapid solutioning. And we have what we call agile seating even. So I think our last day on site was on a Friday, right? That Monday we were working. The entire office was remote. There was very little lag in productivity. We were able to continue to deliver to our clients. And so that's value. There is value in agility because you can be able to rapidly respond to changing environments. Okay, so the full methodology is not just in the way that you structure your teams and in the way you approach projects, but also in the way that businesses respond to change. So by the end of that Friday, the leadership on site and throughout DXC had already come up with a plan and set up supportive structures for our employees. So it's just really the way you're able to respond, the way you communicate, and not being static in your delivery process.
Sure, and Jade, can you share a little bit about what DXC technology actually does, what your areas of focus are, for those who might not be familiar with the company?
We are IoT internet services. We service clients in digital applications, digital transformation, helping them become more agile around the world. And here at the DTC, in the New Orleans DTC, we're focused on that process, taking customers or clients from, let's say, having everything on premises to a cloud. How do you do that? How much does it cost? How do you change from a waterfall structure where there's a very linear line in terms of how you approach a project to Scrum, where the project is broken out to small pieces that add value every sprint, as we call. Every 2 weeks, the client has something that they can use immediately versus waiting 2 or 3 years. So we help clients in that process.
Sure, and I'd imagine much of your work has become immensely relevant for a number of your clients in the midst of this pandemic.
Sure. Yeah.
So Angela, to shift things back to you, given Trapalo's focus on connected health programs, I imagine your team has seen a significant amount of change over the course of these last few months. And I imagine that would require you all to be both nimble and agile in your applications and navigating the changes within the marketplace. For business owners that might be attending the summit today, what will they be seeing?
You know, with any industry, in all of our industries, healthcare is experiencing, we've all seen so many changes and learning to adapt to that very, very quickly. We've seen enormous growth in connected health. You know, if we sit here and think how many of us really had heard of telehealth visits before March or had even had a telehealth visits. And now you look at how many of us have had telehealth visits. You know, I'm sure a majority of people that are watching this and attending have now had their first visit. And it's an excellent example of how healthcare has embraced digital solutions and helped improve accessibility to care. Both healthcare organizations and the patients are starting to see the benefits that they can bring. And as soon as COVID-19 started to make an impact, we at Trapalo worked with our healthcare clients and our customers, and we really had to optimize solutions very fast. These remote care solutions were helping to track symptoms, we're helping to track patients and what's happening with their vital signs and care, and incorporate these new protocols and these new care plans that are creating and changing all the time. As business owners, I think everyone is really focused on safely operating your business and how do you get people back to work. We recognized that in partnership with our clients, and they asked us, you know, how can we use remote patient monitoring for patients, move it into an employee world to bring those employees back to work. And by rethinking population health to an employee world, we were able to take, for example, our smartphone apps and then take a look at those smartphone apps and create a solution that employers can use with their employees to track vitals, which are temperatures and symptoms. We also immediately sourced thousands of very inexpensive digital thermometers, pulse oximeters that our employers could give out to employees to help track these symptoms. So as far as innovation in healthcare, I think everyone's goals continue to be the same, just shifting to what's needed for those organizations that are out there and help get everyone back to work.
Thank you for that, Angela. So across all three of your remarks. I think we have heard a lot about the embracing of new solutions. We've heard a lot about rethinking applications and possibilities for existing technology. But I also think as a result of these actions, we're seeing a sort of kicked off conversation about what the future of work and the future of telehealth and telework might actually be. Fernando, I'd like to kick things back to you. In your opinion, what is business going to look like 3 to 5 years from now, particularly as we think about the applications of technology resulting from this moment?
Victoria, I think that is the question of the day. All kidding aside, I typically like to live in the future, 3 to 5 years out, because we're looking at all the technology that we're internally developing, the industry is developing. And I think what you're going to see very quickly is in the healthcare arena specifically, you're going to see experts and expert systems coming together like never before. So envision a radiologist that can go through, let's say, 50, 70 slides a day and diagnose and make their notations and whatnot. But now you pair them with an expert system that doesn't sleep, doesn't take breaks, doesn't get upset, etc. And that system is looking at many, 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 many slides. Now, it only kicks back to the radiologist the elements that it sees as potentially being, in this case, let's say positives, a melanoma, a suspected melanoma. It sends that back to the radiologist so that he or she can look at it and validate that that's the case. So whether it's in that area of healthcare or in other disciplines, in really a lot of professional services, you're going to see an expert and an expert system working together like never before. That's one aspect. The other aspect that the colleagues are talking about is the ability of very fast networks, great sensors, cloud technologies, and powerful deep learning, machine learning, and AI coming together to create around you, especially for healthcare, the concept of connected intelligence. And so the connected intelligence is that it's constantly monitoring, if I wish, all of my vitals real time. And not only the external sensing, but now smart capsules that have been around for a while that one can take, and it identifies also what's going on inside your system. There's a number of different technologies that are existing that is going to, I think, quickly revolutionize the way that telemedicine can work in this space to enhance what we've already seen. And that's a couple of different dimensions. And then there's the dimension of mental health. Yes, society is becoming a lot more productive, but we're still humans. So the element of mental health and how one monitors it and assesses it and keeps people, well, is going to be another key area, because isolation has to be addressed. And it is probably one of the key issues that I would look at and say, how can technology apply itself to that domain?
Absolutely. Jade, I want to hand things back over to you, really piggybacking off of some of Fernando's remarks. As we're thinking about the shifts we're seeing in the marketplace, there also have been a number of conversations about trends within technology more broadly. When we look at some of the data, particularly around disparities, inequities, and representation within tech, there's a growing conversation about how those disparities are informing some of the innovation we might see in this new product development that we're talking about. So would love to hear your thoughts around greatest opportunities and greatest challenges that you envision for the tech sector.
Well, I think, and thank you for that. I think the greatest opportunity is the issue, the underlying issue of diversity and inclusion. There's a huge challenge there. I just saw something the other day. The employees at the CDC Black and brown employees, 1,000 of them, signed a letter talking about the inequities within that organization, about them not being promoted, and about their issues being ignored, about scientists not leading some of these initiatives. And so you're in the middle of a pandemic, and the people that are being the most affected are Black and brown. And then within the leading organization that we're listening to, we don't have as much representation that we need to have. So that's an issue. And I think throughout tech, that is an issue. So the opportunity there is, now that we have that light, now that we can see what's going on, I think we are in a space, in a place of momentum. We can look at some of the challenges we have with pipeline, and getting some folks into tech. People can now, who are interested, there are numerous free resources online. We just talked about one a little bit earlier. There's a game camp that's coming. Microsoft is sponsoring. It is also sponsored by Unity. It's a free 5-month boot camp for anyone in Louisiana over the age of 18. It is a tremendous opportunity. It is going to be held virtually. It is going to take you from conception to completion. There are numerous skills you could learn: program management, 3D animation, music and audio, and all sorts of skills that direct straight to jobs. At my team, the team that I manage at DXC, we actually utilize Unity, right, to help us develop an AR and VR technology. So this is a tremendous opportunity that needs to be broadcasted, and we need more of it. Because obviously we have some underlying issues. I think there's some cultural issues within tech and keeping people out and not promoting. We have, I think there's an issue, I think it's called Like Me, where you promote folks that are like me. We need to combat that a little bit more, a huge amount. We see this numbers or something about, if you get into tech, if you're a woman, for example, 4 out of 5 women that get into tech get out of it because they're not comfortable. So those are conversations that we need to keep repeating, keep having, keep drilling down to the core root causes of them, and keep railing against, because technology is the present and the future. It's some of the things that Fernando is saying, those things will be happening in the future. Technology isn't going anywhere. It is probably one of the few industries that are really growing, and it touches every other industry. So it is important that we have presence there. So yeah, that's our greatest opportunity at this point.
Sure. I mean, I love this sort of theme I'm seeing across everything that you all have been saying around rethinking just how we approach tech, rethinking the applications of existing tech, rethinking the way our technology connects and enables us to better achieve outcomes, particularly from a population health perspective. But to your point, Jade, really rethinking what our hiring pipelines look like, rethinking the folks that are actually working on developing this technology to ensure that it is as representative, as inclusive as possible to achieve best outcomes for all people. Fernando, given your role at Microsoft, I would love to hear a little bit about your priorities as it relates to procurement and supplier diversity, and how some of that might connect to Jade's remarks.
Absolutely. I think Jade is right on. I think she's very wise, and she's looking at it really the way it has to be worked through, which is we're at the point in time where I think society has pushed and said, no, we want to have our voices heard, not only in the social arena, but in the business arena, in the educational arena. Remember, a society isn't successful unless you have as much quality education as you can possibly have, unless you can build a professional career or a business career in entrepreneurship to build wealth for yourself and your family, and lastly, to have a political voice. So those 3 things have to be underpinning everything that we're talking about here. finally moving in that direction. But that question specific, what we're trying to do here at Microsoft is we've launched a number of different initiatives. I mean, anyone that wants to go to my LinkedIn page, I posted, and you can click on, I had the posting when we announced in our team that we would spend $500 million additional in supplier diversity spend specifically around the African American community, and we would double the number of African American suppliers within the next 3 years. That's building on top of a base that we're doing about $3.7 billion currently. So we're trying to push. We're trying to push. But what Jade is talking about is truly the key, right? The key is looking at trends. Healthcare is evergreen, right? You know, baby boomers, whether in the United States, which we have 85 million baby boomers, or in areas like China, which has probably 350 to 400 million baby boomers. You look at Italy, you look at areas like France, they have these same baby boomer issues, Japan, etc. So if you figure it out here, it'll also extrapolate there. You have aging populations, you have what we've been talking about here of really an accelerated digital transformation around healthcare, you know, about $300, $400 billion market, great place to be playing in. And then you have yourself. If you're a young person, look at data science, look at that whole area, it's exploding. People are getting recruited from school before they finish. So being a data scientist today is the gold, right, within computer science. But even exposing yourself to taking classes, like we have LinkedIn Learning, when we acquired LinkedIn a few years ago, it's very good. So you can go in there, and you can do just-in-time learning. So you can do a few classes in, hey, what is this notion that Fernando's talking about? What is machine learning all about? What is AI all about? And most of the time, people are very intelligent. Once you take 1 or 2 courses, it demystifies the whole thing, and it makes it much more digestible, and then you can get your arms around it. Our communities are extremely intelligent and creative people. It's just on the technology side, a lot of people just haven't been exposed to it. And as anything you're not exposed to, you just don't know about it. You don't see yourself in the middle of it. But there are people that have been very successful, and you're seeing more and more of them pop out. There's an African-American lady that just sold a company very recently around autonomous vehicles to Apple for about $1 billion. Fellow I know, an African-American fellow from New York, Chinatu, he also exited very nicely, close to $1 billion on his exit, Hop Stop. So you're seeing more success, and it's being more promoted, which is a great thing. I think it's a great time to get involved. I think when we talk about who's going to create like the future, the data scientists, people that are creating AI, I think should be extremely diverse. Men, we need more men and women that are diverse, because you can't, like, just on the female side, half of the population cannot be excluded from the conversation. So I'll rest there, but we need more diversity in creating AI that truly encompasses all of society.
That's absolutely right. Point well taken. So we have about 5 minutes left, and I want to open this question up to anyone who wishes to answer it, but it really is building on sort of this last discussion about people getting more involved in tech and creating more pathways for engagement and exposure. For individuals or business owners who are watching at home who are interested in becoming further engaged in the tech industry, what should they be thinking about in the midst of this moment of rapid adoption and economic volatility? And I will open that up to the floor.
Tech, I think you should try to, I think that's a piece of what Fernando was talking about in terms of digital transformation. There is always space for you to be in tech, right? So, you know, we have insurance companies who, when you look at them on the face, are insurance companies, but really they're tech companies, right? The tech is driving their innovation. Because the population is so tech savvy at this point. You almost have to have a footprint in technology just by the way you engage with your customers. So it is very, very important to look for ways to engage, even through something like social media. Tech is everywhere. It is across industry. So in this way, it is growing. You have to be involved. I think it's a safe bet. When you talk about digital transformation, and I'll go back there, for small businesses, and in terms of being agile as well, upgrade your hardware. Start with that. So a lot of businesses are still, having big and bulky desktops. No, now we need laptops. We need high-powered tablets. Make sure that your intranet or your internal networks are accessible through any internet connection using a VPN so that it's secure. And also fully utilize some of these collaboration softwares, Teams, Zoom, Skype, and also use Jira and Confluence to manage your projects and Azure DevOps. So yes, there's a technical way to approach everything. Some industries are more prone to really be stagnant in the way that they do their business. And, you see banking, some smaller banks are still doing things with paper. Try to digitize that, because that ultimately will keep you current with what's going on with the customer.
Angela, Fernando, any final thoughts from the two of you?
I take what you said about rethinking and rethinking, healthcare, focusing on that and, where we're going to be today versus where we're going to be tomorrow. Everybody today has touched on that, and there's enormous opportunity. And, thinking about the patients that are out there and how the demographics are going to change over the next 10, 20, 30 years. There's some amazing opportunities and things that we're not even thinking of right now. So just that healthcare innovation and always trying to stay on top of it and really what's the next step going to be? There's enormous opportunity out there.
I'll hand things to you to take us home.
From my perspective, I think that it's an exciting time. I think everybody needs a friend like Jade, person that is on the ground, that understands what's going on tactically, and kind of guide you through the digital transformation journey. I think it's great. I think one does have to be informed about the mega trends and then start to connect the dots. But it's all about, you're an expert. If you're a business person, you are an expert in your key area. You don't have to be an expert in technology. You just have to find that expert to team with to create some additional value. So I would say it's a time of learning. You want to be a continuous learner. You want to go into platforms like LinkedIn Learning, et cetera. You want to always be looking at what are the new products that the corporations are creating, and then how would I use it in like specific domains like healthcare. Lots of opportunities. I wish we had more time, but it's a great time. We just have to, get through this, and we will.
Well, thank you so much, panelists. Angela, Fernando, Jade, appreciate you joining me, and thanks to all of you for tuning in.
The mask. Thank you, everyone. So thank you, everyone. What a wonderful panel. Thank you for that insight and tremendous information that we've shared today with our audience. And here at the Hispanic Chamber of Commerce, we have a commitment to continue educating our community, continue providing resources, building capacity in technology, which is one of our big focuses, digital literacy, and that way, access better opportunities in general and economic development, which is what we all want. And definitely in the healthcare field, we will continue working on many programs. Please stay tuned to more to come. We have many workshops and seminars programmed for the rest of the year, and I know that you would want to join us for those as well. So important topics coming up. And I would be remiss if I don't thank our sponsors again for supporting our efforts today and joining us in this important program. So our presenting sponsor, AT&T, Cox Communications, Humana, Blue Cross and Blue Shield of Louisiana, Healthy Blue, Verizon, New Orleans Business Alliance, Ochsner Health, GenCare Senior Medical Center, Hyatt Regency New Orleans, Downtown Development District, and PSAV. Thank you very much. And with that, we conclude our 2020 Healthcare Technology and Innovation Summit. See you soon in another one of our programs. Thank you very much for joining us.